Okay, so good evening, everybody. I hope you're all arriving safely into the webinar this evening. It's great to see you all, and you're all very welcome as always. So I'm Catherine Morrow. I'm the Operations Director for the IAOP, and I'm really delighted to be hosting this evening's webinar, which is actually on the role of pharmacists and pharmacy teams in vaccine stewardship in the mass vaccination clinics. And I guess, ultimately the aim of these vaccination clinics is to help vaccinate our Irish population expediently and safely. And whilst the needle in the arm is the end goal and is the image that we all see in the news, there is a huge amount of governance and rigour at an operational level to ensure this happens safely, effectively and efficiently, and of course with a minimum amount of wastage. Pharmacists and pharmacy technicians are already playing and will continue to play a pivotal role in the medicines management of these clinics, more of which you'll hear from our panel this evening. So I suppose in summary, I'm hoping the information in this webinar will be an opportunity for you to learn about the role, for you to see whether or not you'll be interested in participating in the role, and very importantly, how you can get involved.
Wait, that's not celebrating.
Someone could mute their microphones there, please.
Yeah.
Thank you.
There's just a few microphones unmuted, and actually I'll just come to that now. So I'm just going to be handing you... Sorry, Audrey?
No, go on ahead. Okay,
perfect. Yeah, just some domestics before I hand over to the panel. I know you're really looking forward to hearing from them. Just to whiz through some housekeeping points. So to the microphones, it's really important that you keep your microphones muted if that's okay, because it does cause interference on the line. If you have problems with sound, it often helps to come out of the webinar and come back in again. That's always worth a try. In terms of questions, we do plan to leave a time for a Q&A session at the end. But in the meantime, you should see a chat box in your toolbar. So do please feel free to type your questions to the presenters in the chat box as we go along, and we'll get to as many of them as we can at the end of the session. It would be remiss of me not to acknowledge that you probably have many questions relating to the vaccination services more generally. Our presenters this evening will only be able to answer questions that fall under their remit, the remit of medicines management and vaccine stewardship, as opposed to, for example, the role of the vaccinator. Where possible, though, we will endeavour to forward questions that can't be answered this evening to the relevant stakeholders for their consideration. Okay, so finally, the webinar is going to be recorded and should be available to view on the IAOP website in the next few days. Okay, so I'm not going to, no more talking from me, I'm going to introduce our panel. So our panel, all three of the members of our panel have been instrumental in developing the medicines management processes and policies for the vaccination centres. So Fionnuala King works for the HSC as Chief Pharmacist of the Acute Hospital Drugs Management Programme. Muriel Pate is a medication safety specialist working in the National Quality Improvement Team of the HSC. And Joan Peppard is vaccination pharmacy lead for Dublin and Mid-Leinster Hospital Group and responsible for recruitment and process implementation. And she's actually currently leading the medicines management processes in the City West Vaccination Centre, and therefore is very, very well placed to give you a really good insight into the role. I'm keeping my fingers crossed that Joan is going to be able to join us by phone because we're having some difficulties. So let's all keep our fingers crossed that Joan can join us. But in the meantime, I'm going to actually hand over to Fionnuala to kick us off. So I'm going to stop my screen share and invite Audrey to start sharing the slides.
Now, Catherine, are they showing up okay?
Brilliant. We just need to go back a few slides, I think.
Oh, we do indeed, actually. Perfect.
Perfect.
Great. Thank you very much, Catherine and Audrey, and to the IAOP for inviting us here today. My name is Fionnuala King. I'm the Chief Pharmacist for the Acute Hospital Drug Management Programme. We're the pharmacy function for acute operations, which is where the hospitals reported to. And I think it was the 21st of December, my boss came to me and said, they're starting looking at the vaccination of healthcare workers and they need pharmacy input, Fionnuala, so would you mind going to a couple of meetings? And so clearly I said, yes, that's not a problem. And that's 4 months ago. And to be honest, it's taking up a huge amount of my time. So the piece of work that we'd like to share with you today is as a consequence, because I recruited my colleagues to, Joan was there before me, and we've recruited many sundry pharmacists to work with us on this one. Next slide. So what we're going to talk about today is an overview of the plan for the vaccination centres in the COVID-19. I'm just going to move the little pop-up because I can't see all the slides. The vaccination programme in Ireland and their governance. And I do think we'd like to talk about what we mean by vaccine stewardship and why, as a pharmacist, I think it's really, really important. What have we learned from the COVID-19 vaccination programme so far? And if we as pharmacists choose to go and work in these vaccination centres in the medicines management role, what will it entail and how should I find out more? When I went and was involved in the conversations around the vaccination of healthcare workers, well, first of all, I was told that the healthcare workers were going to go live at the end of January. But as you all know, a decision was made because of the background rate of COVID that we needed to start vaccinating the healthcare workers from the 29th of December. And when I was in those conversations, and then those conversations were extending to the standalone vaccine clinics, because initially that vaccination program was being run from the hospitals, it became really clear that nobody had thought about that in the hospitals, the medicines management was being done by the pharmacy departments of the hospitals. And that when these vaccination programs went to standalone clinics, the hospital pharmacy department wouldn't be there. And the entire piece of work that my hospital colleagues were doing and doing supremely well, nobody had thought about how that work was to happen or who should do that work or what that work entailed. And it was at that point that I spoke to Muriel and I spoke to Joan and I spoke to a number of other colleagues who had hospital experience of vaccination clinics or had worked in some of the GP clinics at the weekend doing extra hours. And I said, I think we need to start a medicines management group, and can we come together and do that? And I went to the subgroup I was on. The chair said, absolutely, form a working group. They can report into us. That's a really good governance structure. It makes sense. And the piece of work we're going to go through is the work, that output from that medicines management group. So I have to acknowledge the work of my colleagues, Maria Angela Thoma in the NIO, Mary Philbin from the AMRIC, and Brian Cleary, who came in from the Rotunda, and many other colleagues who have come in and out as we've needed expertise. So it would be unfair of us to talk about this without acknowledging all their hard work as well. So Joan is, as Catherine said, working in City West and has been, she's the lead for Dublin Midlands, first of all. So she's taken on a huge amount of work, but also she's in the clinic in City West. City West is doing about 1,000 people a day, and their systems are running, and they've tested the software, they've tested their flow and processes, and they're ably and easily managing 1,000 patients a day and are keen to upscale, and the vaccine supply becomes strong enough. So I don't know, has Joan managed to come on the line?
Can you hear me?
We can.
Audrey, could we go to the next slide?
Yes.
So we can see pretty pictures of City West while Joan tells us about her experience.
Lovely, there you go.
Thank you.
Thanks so much, Fionnuala. Just to say, it's been an absolutely unique experience for me working in the City West Vaccination Centre. To have a team right from the background team, as Fionnuala has described, administration, management of the hospitals, management of the HSE, everybody, every healthcare worker who's been vaccinated, all saying we want to contribute to this. So when you go to the City West Vaccination Centre, from security out in the car park to the reception, to the vaccinators, to the pharmacy, to the support people there, everybody is gung-ho and focused on one thing, and that's getting vaccination into people's arms. So the fun and games we had when I started up in City West, which was on the 1st of March, was initially they showed us our pharmacy room, which they were calling the vaccine prep room. And I smiled back at them and said, and where's the rest of it? So very quickly we moved from one room to 3 rooms, and pharmacy is absolutely central to the vaccination process. And the respect that the profession is getting for their expertise in medicine management is amazing. And it's great to hear at every meeting, can we get pharmacists? When are the pharmacists starting? And look what pharmacy is doing for us. So if you want to have a quick look there at the screen, and I'll take the first picture top right, that is part of the City West Vaccination Centre, which has been designed by estates. Again, a massive contribution to the whole vaccine process. So when you come into the vaccination centre, you're met with 16 reception areas. You're checked in through one of those, and then you move around to one of 50 vaccination bays. At the moment, we're only operating on 20, and this will be ramped up very quickly during the month of April as vaccines become more available to the country. Looking at this picture at the top right, still, if you head on down visually to that red hand hygiene, in there is the main vaccine prep area. But prior to that, we have two other rooms, goods inwards and goods outwards. In the goods inwards room, we have staff who are putting together the leaflets, the patient information leaflet, the HSE booklet, and the post-vaccination advice leaflet for each of the recipients. And they're left at reception, and staff under the responsibility of the pharmacist make sure that reception is kept well stocked with those. The goods inwards then receive all other consumables that the vaccinators will want in their vaccination booths. So that's the handheld gel, the wipes, anything else they might need in the booth while they're there as a vaccinator. And of course, then we manage the vaccines coming in and loading them up onto the COVAX system. And we also manage the injection supply, the needles, syringes, and vaccination cards. So what you're looking at then on the blue tray on the table at the bottom left-hand side, in that we have orange combo needles and syringes. We have a flag label to attach to each vaccine. We have a list for the vaccinators to document, in the case of AstraZeneca, the 12 doses, the 12 names, so that when they're finished their vial, they can double check and make sure that it's clear that those 12 people have received the vaccine. And on the table, you can see the barcode label that we will attach. And thanks very much to Fionnuala and the work she has done with GS1 Ireland, we have what I call a dinky little computer system, and it allows us to issue vaccines. We can issue in ones or boxes of 10, and we get those labels that come out there. This automatically documents the time we issue at, so I don't have to worry about adding 6 hours. It's done for me. The table then on the bottom right, the computer screen there, on the orange section, and these are colour coded to match the colour codes that we're attributing to each of these vaccines. So orange there is showing up as AstraZeneca, and we are able to see how many vials we have in circulation, how many vials have come back into the pharmacy, and as they come back in, we're documenting how many of those achieved 12 doses, 11 doses, or whether, for example, some doses had to be wasted because there might be the bung in the, some bung can sometimes slip into a vial and you might end up with some wasted doses. All of that can be documented so you can see your percentage success and the average you're achieving for your centre. In the case of City West at the moment, we're achieving a 67% rate of 12 doses per AstraZeneca vial and about 33% ardent. So if I have 100 vials, the maximum I can achieve would be 1,200 doses, and what I'm currently achieving is 1,169. So it's operating very well. Thankfully, Fionnuala and all the work she has done in the background, she has managed to achieve approval for this computer system or software. So we are testing it here. Donald Carroll is testing it in Kilkenny. We're making a few more tweaks and hopefully it'll be ready soon to go to all of the vaccination centres around the country. So in terms of then the pharmacy staffing, what we are hoping to achieve is two pharmacists available for every single shift. There will be the shifts for the pharmacy will, I'm sorry to say, start rather early in the morning because we have to start about an hour ahead of the actual vaccinators arriving, and we have to finish after the vaccinators finish because we have to wait for the very last vial to come in. So our schedules will be something like 7 a.m. to 9 p.m. So we hope to have 2 people on shift at every time, 7 days a week. And the pharmacy will be supported by pharmacy technicians and also by front of shop staff, or in the hospital, the equivalent of a multitask attendant. It's amazing. As I say, it's a unique experience for me to have everybody working on the one topic all of the time and all focused on the one thing, and it's great to be part of it. So I'm aware that there was some degree of confusion about salaries to be paid. I wasn't party to any early discussions on this. What we have agreed for the moment, for City West certainly, or for the Dublin Mid-Leinster area, which is the only area I can talk about, is that we would pay a salary equivalent to the senior pharmacist salary scale in a hospital. That does not mean hospital experience is required. That's just the salary that we are using as a scale against which, and I am told by my community colleagues that would be competitive with a locum rate, and the duty pharmacists will receive that salary, and it's up to them to talk to the recruiting agency. For Dublin Mid-Leinster, we're recruiting through CPL, and if anybody wants to talk to me, I'm happy to talk to them. Okay. I think that's all
Cool,
the technician role, it will be to support the pharmacist in the dispensing process, and also to accept the return vials, and to assist in the supervision of multitask front of shop equivalent staff in managing all of the goods inwards and reordering of all the consumables. We currently are not drawing up doses in City West. We're leaving that with the vaccinators. There are some items to be clarified, but I'll pass that back for the other presenters to deal with. All I can say is the atmosphere is great, folks. There's a buzz about the place when people are in being vaccinated, and it's a great experience. So with that, I'll pass it back. Thank you. Thank you.
Not at all. Thank you very much, Joan. Audrey, could I see the next slide? I can see there's a lot of questions coming in. So hopefully some of them, most of them, I think will be addressed as we go through. So as Joan said, when I realized that there was no understanding of the amount of work the pharmacy and the hospitals were doing as part of the hospital vaccination programme, we started from scratch and we started from zero. And one of the things we've had to do is devise a workforce model for the vaccination centres. And that has been signed off by National HR, by the vaccination subgroup HR committee, and most recently today by the Central Vaccination Clinic HR subgroups chair. So this will go out to the hospital or to the leads tomorrow. And the structure is that we have a pharmacist in charge who is the responsible person, and the pay scale on that is at Chief 2, and we had to go on a HSE pay scale. The duty pharmacist is to be reimbursed equivalent to a senior pharmacist, and there is also pay scales in there in grade codes, which is what the HSE HR department call them. So I have to call them a grade code for pharmacy technician, for ancillary staff, and also for logistics and support, and in the roles that Joan has described. And there's a sliding scale of, we work 37.5 hours a week on a HSE contract. Some of these vaccination centres will be open for upwards of 98 hours a week. So there's been, I have never had to do a complicated roster. I've only ever done pharmacy rosters. So that's been a piece of work and learning for me, but that has gone out. It's been, like I said, National HR have assessed it. And as Joan said, our minimum is that for 11 booths, there should be 2 people in the pharmacy team. And then that slides up as far as we've done a ratio up to 50 booths, where is the largest we know about at the moment. But again, if that changes to 60 or 75, as some of the sites are talking about, as vaccine supplies become available, the ratios will change. Like I said, that's been agreed by National HR and should be circulating with the people who are doing this. Now, I have recruitment details at the end, so let me get to the end. Can I get the next slide, Audrey? So the overarching objective of the vaccination programme in Ireland is that we ensure equitable access to a safe and effective vaccine. And the goal is to limit mortality and morbidity from COVID and that we protect healthcare capacity and we enable social and economic activity. To achieve this, it's essential that there are appropriate medicines management processes in place in vaccination facilities so that the quality attributes of these sensitive and fragile products are maintained and that the vaccinations are administered safely, effectively and efficiently. In every document we produce, this is the kind of background statement we put out there. So what we are saying up front is we want this to be safe, effective and efficient. And that is the reason why as pharmacists we approach it the way we do. Next slide, Audrey. So just to put this in context, this is from the government's national COVID plan. I'm getting the pop-ups right in the middle of my screen, so I'm not sure how to deal with that. There we go. I'm going to move it on. Bláthnaid, I can see your question, but I can't read it. So just to say here, we're in this mass ramp up. I mean, the rate limiting step for this program is the availability of vaccine. And we're in this mass ramp up phase. So we're talking about what was previously known as a mass vaccination centre, but they're now calling them centralised vaccination centres because some people went, well, 10 booths aren't as mass as me as a 50 booth. So we have one generic term, centralised vaccination clinics. We're in this phase, that acute leg, where we're hoping we get access to lots of vaccine and we can vaccinate lots of people very quickly. And then once we peak, then we'll have a gradual tail off. And this piece of work is to cover these vaccination centres. Next slide, Audrey. And where are they? Well, I think this is in the public domain, but just in case they aren't, HSE Estates put in a phenomenal amount of work to design the vaccination centres. Equivalently, somebody also did a load of work and they looked at our population and they looked at how far people would have to travel and they selected sites for these vaccination centres and a huge amount of work went into it. Now, I think everybody is aware how political our vaccination programme is and the level of media scrutiny and the level of political interest in it. But my understanding is that they've managed to hold the line and hold those vaccination centres in a way that, again, is equitable for the population to access vaccine. Next slide, Audrey. And this vaccination centres, this again is in the public domain, but here is the list of the 38 centralised vaccination centres. Every county has one, some counties have more than one. And depending on the size of the actual space available, the number of booths was determined. So the largest is City West, the Helix, then we have Sligo IT, the Galway Racecourse, and then down some of the GAA clubs, the Midlands Park Hotel and Portlaoise. So it's a sliding scale. It was anything from 50 to 10. And as I said, there is a real chance that the bigger ones would scale up to 60 in City West and possibly 75, depending on blah, 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 blah. And vaccine supply, because there's no use having loads of booths if we don't have vaccine for people to administer them in. So those are them. That's the size of them. That's the scale of them. Next slide, Audrey. So Muriel, I think you're taking over for me here. Am I correct?
Yes, great. Yeah, thanks, Fionnuala.
No worries, and I'll start answering questions, Catherine.
Great. So thanks. So I suppose we've had a number of queries over the last number of weeks just about the governance of the vaccination clinics, and I suppose in particular whether if someone has, say, a supervising or a superintendent role in another setting, whether that somehow carries through to the vaccination clinics and where they stand there. So the PSI have given us some very helpful guidance. So I might just run through that quickly. So essentially, you know, the centralised clinics are under the governance of the HSE, and they don't fall within the definition of a retail pharmacy business as per the Pharmacy Act. So the operation and governance of the clinics don't fall within that remit, and neither do the regulatory rules established as part of the Act. So the superintendent and the supervising pharmacist don't apply in the vaccination clinics. So essentially, you know, a registered pharmacist who's working in any of the clinics does so under the governance and oversight of the HSE. But of course, we have our responsibilities, you know, as per the PSI Code of Conduct. So every pharmacist has their professional responsibilities and, you know, expected to use professional judgment and clinical expertise to meet patient needs and ensure patient safety. So that's just to kind of clarify that piece. So essentially you're working under kind of HSE governance in those clinics. Next slide, please. And then just in terms of the clinics themselves, so the vaccination centres have been set up to have a clinical lead on site. But that person can be from any of the vaccinator groups. So it may well be from a nursing background, someone from a nursing background. It could be someone who is a paramedic and so on, or it could indeed be a pharmacist. There may or may not be a doctor or a prescriber on site. And that's quite important because we've also had queries about what other medicines may or may not need to be stocked on site at those centres. And essentially the only other, apart from obviously the vaccines themselves, the only other medicine which is the core, part of the core stock is adrenaline. So obviously vaccinators all have to be trained to use adrenaline should it be needed. And that will be held on site, but there won't be any other regular medicines stocked on site. And really that's because there may not actually be a prescriber available to prescribe, administer, and so on. And essentially, if there is a medical incident or an emergency, the response which is agreed is that an ambulance would be called. So all of our vaccinators, they have basic life support training, but there's not provision for advanced life support or advanced emergency response in those centres. So next slide, please. And then just the training requirements. So I think most people will be familiar or have an awareness of the training requirements for vaccinators, so that there's the PSI vaccination pathway requirements. And all vaccinators will need to have completed all of those requirements, and that's regardless of the setting that you're working in. So it applies in the vaccination clinics as well as in community pharmacies, for example. But for this particular role, for people working in the medicines management role, really the main requirement is that pharmacists need to have completed the HSE training module for the particular vaccines that they're going to be working with, so that they're familiar with all the relevant aspects which could arise in terms of responding to queries and so on, and making sure that they know all the particular requirements of each vaccine. But pharmacists working in these roles don't need to have gone through all of the other training requirements as part of the PSI pathway. And all the training information is available on the IIOP website if you do want to double check that. Next slide, please. So we've mentioned vaccine stewardship, and I suppose I just thought it'd be worthwhile just touching on what we mean by that. So I suppose essentially stewardship is really all about supervising and managing something very carefully, or perhaps something very precious. And I suppose I can't really think of anything that's more precious than the COVID-19 vaccines at the moment. So it is a very precious resource. And as we all know, the rollout of the vaccines is underway, but supplies of the vaccine are still limited at the moment. So although we're using vaccines as soon as possible after they arrive in Ireland, it's really important that we maximise all available doses to make sure that we absolutely minimise any waste. And that's just to maximise societal benefits in terms of the health and economic and social benefits of the programme more generally. Next slide, please. So there's a number of aspects in terms of vaccine stewardship. So I'll kind of run through them over the next number of slides. But I suppose the first one is obviously just correct management in terms of making sure that we don't have any unnecessary waste. So we all know at this stage that they're very fragile, and there's very particular temperature and expiry and movement requirements that are associated with managing the vaccines. So maintaining the cold chain is obviously really important, and especially when you think about managing the number of vaccines that could be going through some of these bigger centres over a few days. If there's a problem with the cold chain, then that could potentially impact on thousands of vaccines, which would be a real significant problem. So making sure that we minimise any waste by making sure that they're managed properly is really important. And then adhering to all the handling requirements, because obviously they have a short expiry and particular discard times. So making sure that we make sure that people are adhering to all those times. Next slide, please. And then I think everybody probably has an awareness of the additional doses that may be in some of the vials. So although the first two vaccines, the Moderna vaccine and AstraZeneca, are both designed to be 10-dose multi-dose vials, we can routinely achieve 11 and in most cases achieve 12. So at the moment, as Joan alluded to earlier, in about 2/3 of cases, they're achieving 12 doses in City West at the moment for the AstraZeneca. And then for Comirnaty, so the Pfizer vaccine, that needs dilution first, and then there's routinely 6 doses can be extracted from that vial, and sometimes 7, but it does depend on a number of factors. And there's been some really superb work done by some of the hospital teams. So our hospital pharmacy colleagues, sort of led by Professor Brian Cleary in the Rotunda, and a number of other hospital colleagues in some of the other centres, who gathered information about the factors which influenced whether or not 6 or 7 doses were achieved when those vaccines were being used in the hospital. And I'll just touch on what some of those are. But we do, in the next slide, but we do have, you know, as we mentioned earlier, the way to track the vaccine through the clinic, so that we can identify and track the yield from each of the vials. And that can be useful. It can help us perhaps, you know, inform training needs and so on. Next slide, please. So one of the most important things which has been identified, not just here but internationally, is the need for low dead volume syringes and needles to try and minimise any of the vaccine which is left in the syringe. And I'll show you a picture of that in the next slide. But essentially, the dead volume is also sometimes referred to as dead space, and that's the product that's left in the hub of the syringe after the injection's been given. So essentially, those combinations have a very tiny volume left in the syringe of less than 0.035 mils. And actually, the procurement team in HSE have done great work in that the syringes and needles which are available to us for the vaccination programme in Ireland are all low dead volume syringes. So essentially, we don't have a particular problem with the fact that you know, we routinely have these available to us. There are slight variations between the different batches, but they are all low dead volume syringes that are in use. And that's not necessarily common to all countries. So there's, so for example, there's reports, I was reading a report about how Japan don't have any low dead volume syringes, which is meaning that they're only getting 5 doses from each of their Pfizer vials. And other factors which are important, so there is some batch variation. So some batches seem to be easier to achieve the 7 doses than others. And the staff involved, so, you know, trained and experienced staff did have, you know, greater success in getting that extra, you know, extra dose out of the vials more routinely. Next slide, please. So this is just a quick visual, just so people are aware of what we're talking about with the low dead space. So essentially, you can see that on the right-hand side of your screen, the nib of the syringe moves up further so that there's less. The orange is essentially the vaccine that's left over. So on the left-hand side, that's a regular syringe. There's more of the orange, which is the remnants of the vaccine. And on the right-hand side, that's pushed up further and there's less left over. Next, please. Next slide, please. Okay, so moving on, I suppose, to some of the other issues which could pose problems in terms of vaccine delivery. So some of the medication safety issues that we're aware of internationally. So there's been a number of reports from multiple countries now about dilution errors with the Pfizer Comirnaty vaccine. So it does need to be diluted with 1.8 mils. And then, you know, you'll be aware that there's the rotation of the vial before you move to the vaccination stage. So there's reports where undiluted vaccines being given in a number of countries, such as Israel, Singapore, and Germany. and also reports of the wrong volume of diluent being used. So just 1 ml has been reported a couple of times that we're aware of. And actually that's kind of important for us to just be aware of, because it was only at the end, or towards the end of the vial, when there was a query about why they were struggling to get the 5th dose. And it was only at that stage that it was realized that the wrong volume had been used. So that kind of thing is really important for people working in the medicines management role. If you're getting a query like that, then, you know, to think about some of these kind of issues and whether that might have been a factor. In terms of, you know, multi-dose vials and biological contamination, so, you know, typically we've moved away from multi-dose vials, certainly at the patient side, you know, or close to the patient, for many years now. And typically with a vaccination program, you'd be using pre-filled syringes. But due to the kind of the time pressures in terms of getting the vaccines to market, that's only been able to be achieved by the use of multi-dose vials. But they do carry, you know, a risk of biological contamination, especially when you're piercing a vial multiple times in a patient area. And it's just something that we all need to be very conscious of and very careful about, never making sure that all staff are very familiar that you never go back into a syringe, never go back into a vial a second time. And then the other issue which is starting to come up in reports internationally is just challenges and difficulties and errors with scheduling the second dose. And it's certainly starting to become, you know, we're aware of issues in terms of maybe people who may or may not have been in the same location for their first or second dose. So if someone's admitted to hospital during the time frame when they were due a second dose, or, you know, trying to identify what people had across transitions of care. Like with other medicines, it's always a challenge, but you know, it is proving to be something which is challenging in practice. Next slide, please. And then in terms of the vaccines themselves, so at the moment we have 3 vaccines in use, so and not really very much Moderna. So the 2 which are used, I suppose, most often at the moment are the AstraZeneca and the Pfizer. But we are very, I suppose, aware of potential risks with having more than 1 vaccine on site at any given time. And you'll see from the pictures there that for example, the size of the AstraZeneca and the Pfizer, sorry, the AstraZeneca and the Moderna vaccines, the size of the vial is almost identical. So, you know, if you don't read the label carefully, it would be very easy to have an incorrect selection there. So essentially, we're really kind of making sure it's very clear that there needs to be very careful procedures if there is more than 1 vaccine on site, and separation in time or place. So separation in time might mean having a morning session where it's all just vaccine A, say AstraZeneca, and then an afternoon session with, say, vaccine B, which might be Pfizer, and having a timeout in between those sessions. Because the other thing is that the vaccinators are going to be drawing up a different volume depending on which vaccine they're using. So there needs to be that separation between switching from one to another to just refocus everyone's minds on the task ahead of them. And the other way it could be done, it would be separation in space, perhaps in some of the bigger centres. So that might mean that 1/2 of the centre is working with 1 vaccine and the other half is working with a different vaccine. And what we're recommending in terms of a setup like that would be that the vaccinators never move. So, you know, people who are coming to be vaccinated should move through the centre according to which vaccine that they're due to receive. But, you know, if somebody did end up at the wrong side, they have to move back to the correct channel, and the vaccinators don't switch between what they're administering within a given session. And then in terms of the pharmacy piece and how that would be managed there, so just making sure that we have separate labelling lines for different vaccines, and double check on the vaccine, and separate sections of the fridge for different vaccines as well. Next slide, please. And then in terms of, I suppose, the black market and potential for abuse or misuse, so, you know, anything that's life-saving or life-preserving that's in short supply will create a black market, and that's certainly becoming the case for COVID-19 vaccines. So we've heard of multiple countries where there's been seizure of falsified COVID-19 vaccine now at this stage. And it's something that Interpol are very aware of, and they state that they believe this is just the tip of the iceberg in terms of COVID-19 vaccine crime. So in terms of FMD, you know, I suppose we often wonder about the value of FMD in many cases, but this would be a case where there really is a value in terms of making sure that vaccines are you know, are verified as being authentic. The FMD for the vaccination clinics is done with United Drug acting as the pharmacy as part of the National Cold Chain Service. So, so the FMD decommissioning doesn't have to happen at the vaccination clinics, but it is a really important, it will be a really important piece going forward. At the moment, it's just the AstraZeneca, which is set up as part of FMD, and the other vaccines had an exemption for the first few months, but we understand that's likely to change in Q2, so they'll all be required to go through that process. Next slide, please. And then just to give a kind of a sort of a sample of the range of different issues which have been raised internationally in terms of problems with misuse. So there's been theft of vials, and that ranges, I suppose, from a small number of vials, or even just a small number of doses at the end of the vial, which might walk out of a centre with somebody, right up to bigger quantities, like there's a case in California where 1,000 Pfizer vaccines 1,000 vials have gone missing, and that's under investigation. I understand, I haven't gone looking, but I understand that you can get COVID-19 vaccines on the dark web if you have some cryptocurrency to spend. But what I have found is if you go onto eBay, you can easily track down empty vials. So this is something that we're really aware of as being a potential problem, and it's really important that we retrieve our empty vials at the end of the day and make sure that they're defaced so that the label is scored out with black marker, permanent marker, so that they can't be reused inappropriately. So these empty vials have been found to be filled with other product, maybe just water. And you know, there's reports, for example, from Israel with 2 people being charged with selling empty vials online for $100 each. And that's been reported in a number of different countries. And for example, then people presenting at often older people's doors, offering to give them a vaccine. And there's been cases in the UK where people have been presenting at somebody's door saying that they'll vaccinate them with the COVID-19 vaccine for £160. So these are not so far from home. And actually what's even closer to home is that we understand from the Gardaí that vaccination record cards are now changing hands in Ireland for €50 each. So there's, you know, so all of these things are being reported in multiple countries, and many of them are being reported in Europe and even closer to home. So I think we have to assume that any of these scenarios could play out in Ireland over time. Next slide, please. So yeah, on that happy note, I get to hand back over to Fionnuala to finish off for us this evening.
Great. And Catherine, I'm aware of the time. Because Kath was like, do you need us to keep an eye on the time? I was going, no, there's not so many slides, be fine. I'm not so sure now. So I think the learning for us, for me, and one of the reasons why 3 months of my life has been in this is that we're not exceptional. I think we know that. And everything that has happened internationally can happen here. And as a pharmacist, I have spent a lot of my life following up MedRec, phoning community colleagues, phoning GPs, phoning families, phoning people, finding the information. And if one thing I am absolutely convinced of in this is that we have to have a central record of a single place where we have the information about the patient vaccine, irrespective of the location in which the vaccine is administered. This is complicated. We are running a national immunization program and we're trying to cram it into the shortest possible time. So it has to run smoothly. We have to have good information readily available to do this right. The second doses is definitely making things more difficult, and the intervals, the fact that Pfizer is 4 weeks and AstraZeneca, you get the best result after 12 weeks, has definitely made life more difficult. we have this whole transition of care. So the hospitals are asked to identify the inpatients who are over 70, vaccinate those patients. So, and then if they were going to their GPs, come up with a plan. So to be fair to the hospitals, they went to their census, they established who's over 70, they ordered vaccine, Pfizer vaccine, because we're over 70. So they're getting about 84 hours expiry when it comes into the hospital. Divide out some of the over 70s were over 85 and had got the first dose in their GP practices some weeks earlier. So that whole piece around how do we make sure we get it right? How do we make sure we don't land up with a short-dated product, you know, in an inappropriate location? It's taking, I can't tell you how much time and energy it's taking, and the need for that information to be in one central place, because the GP records have gone in and they're being uploaded as we speak this week. So we need real-time information. And we also have multiple vaccines, and we have different patient cohorts. And in Ireland, traditionally, we don't run huge, extensive national disease registries. So date of birth is in every system. Your disease status, stage of disease, severe, etc. They're not in our very limited e-health systems. And this has all added to the complexity and the amount of time it has taken to find vaccine recipients and actually go out and proactively vaccinate. Next slide. So it has been fairly difficult. So within the clinics, what have we learned? We learned that we need to separate the dilution of the Pfizer vial from the vaccine administration. We've learned that vaccinator training, because really the use of a multi-dose vial is it's aseptic pharmacy technicians do it all the time in compounding units. Clinical staff, not so much. They're very used to single dose deliveries. And the use of a multi-dose vial isn't a core skill set anymore. So vaccinator training to maximize that yield. And I mean, the difference between getting 10 doses from an AstraZeneca vial and 12 is 20% more people get vaccinated from the same vial. And when the rate limiting step for our vaccination program is access to the vaccine, it's just so strange. We're not used to the drugs being the rate limiting step. But here, access to the vaccine is a rate limiting step. So if we get 20% more patients vaccinated for each of those vials, there's clearly a net benefit to us as a society. So our vaccinators becoming more familiar with the skill set is very important. What we do know is that vaccination clinics, I mean, if you're running a 50 booth clinic, not everybody will want to work full time. Not everybody is available to work full time. We're going to have a large enough population of vaccinators, and it's going to be very difficult. People who work 2 days a week and then come back next week. It's very hard to get your skill set up, but it's something that we have to face up to and we have to manage. And we're going to have that, you know, in City West, if it's open 12 hours a day and 7 days a week, then how many hundred vaccinators will have to be worked there to just staff the City West vaccination centre? And they're facing up to that. So next slide, please. And our challenge is the end of day session procedures are really, really challenging. And our end game is, like, we're pharmacists, we don't want to waste anything. We're quite cautious on stuff. And we want to get that at the end of the day, the last patient gets the last dose. And we don't like standby lists. And the reason we don't like standby lists is they're really inefficient. But if you have 50 booths running in City West and you have a vial of 10 to 12 doses per booth, functionally, you have 500 to 600 doses on the floor at any one time. This becomes even more complicated if booths 1 to 20 are on one vaccine and vials, you know, 30 to or 21 to 50 are on a second. How do you make sure you, at the end of the day, the last patient gets the last dose? And we're also getting variable yield. So we can't say for each vial we put on the floor, we have 10 people, because we might have 11, we possibly will have 12. We definitely will have 10. And I saw in the quest, how are you managing DNAs? For the most part, aside from the absolute complications of scheduling, and also people got texts this weekend around coming in for appointments and they thought they were fake texts. So when they were asked why they didn't come up, they said, oh, but we thought it was a fake text because we heard there was fake text going. But anyway, really it's that piece the pharmacy does, and that screen where, you know, Joan pointed out that the orange color, and that's the color of the AstraZeneca vaccine. On that screen, Joan can see how many vials have gone out to the floor, how many vials have come back in because of the barcode, how many vials are out there, how many vials are within 2 hours expiry, how many vials are within 1 hour of their expiry. And from that, you can get a sense if there's 10 vials out there, there's a maximum of 120 doses. hi, operations lead, how many people have checked in but have not been vaccinated? And the pharmacy role in helping to make sure we don't waste files and use standby lists is very important, because the problem with standby is they're very tricky and they get a lot of media attention. And if you phone the nearest, easiest people to get in to get rid of the doses, they aren't always going to be the next people on the list. And if you don't give it to the next people on the list, there will be a headline in a newspaper the next day that you vaccinated people who shouldn't have been vaccinated, because nobody's taking into account that piece that the clinics are trying to do, which is don't waste the vaccine. It's better we give it to the imperfect people who will ultimately be vaccinated than with 1 hour to go, how do we get in the right people? So next slide. So each of the vaccination CVC leads have been given an operating model. And in the operating models, one of the documents embedded in the operations model is this medicines management guidance for centralized HC vaccination clinics. Because one thing I'm really good at is coming up with very interesting titles for documents, not. And this is the piece of work that my colleagues that I alluded to earlier have done. And it's not a really very complicated document. It's not a very complicated thing for us as pharmacists. And sometimes I struggle to articulate it because it's so obvious to me why and this has to be done. May I have the next slide, Audrey, please? And it is talking about the receipt and storage of vaccines. It is talking about who, responsible person, cold chain preservation, monitoring of fridges, receipt of vaccine, how labeling a vaccine, end of sessions processes, secure storage, replenishing the adrenaline in the anaphylaxis kit, and also that piece, because one of the things we have is we are being asked vaccine-specific medicines information queries. And one of our colleagues, Niamh O'Hanlon in Vincent's, was great, and she sent us a kind of their experience and the resources they used for these vaccine-specific medicines information queries. And that's been built into the next version of the medicines management guidance. Next slide, please. And to support these, we've done a series of SOPs, because these SOPs are templates, they're national templates, and the lead pharmacist on a site can access these SOPs and then localize them, so that even if tomorrow a new person walks in and is there for one day, they can access SOPs and know how things work. But generally, the SOP, in my head, it'll be the 80-20 rule, where generally we all do the same thing as much as possible to make it easy for our colleagues to work there. And there might be little quirks locally because of certain local arrangements. You might notice that SOP 4 is absent there. The reason SOP 4 is absent is we actually got sign off on the software this week, about 36 hours ago. So we're in the process of writing the SOP for this software, because we couldn't put out an SOP for software that we hadn't got sign off on the final versions of and the funding for. So, but that happened this week, so that's a good thing. Next slide. And thank you to IMSN and our colleague Niamh O'Hanlon. These are some of the resources that they identified that are in use. And I think, Michelle, you mentioned the vaccine bulletin, there it is, but it's also the actual NIO clinical guidance has huge amounts of information in it. It's about 140 pages long at this stage. And as new vaccines come along, they update it. They're doing a really super piece of work keeping that up to date, and they have an FAQ section in there. And then some of our colleges have done very specific thing, our immunologists around the pre-existing allergic conditions. And then we have questions for pregnant or breastfeeding women. And again, these are super, really high quality documents, and they're available, and we want to just make sure that the pharmacists have a resource where they can click in, know where these are, know what they are, and then go and answer the queries, again, to make life easier for us. Next slide. So one of the things I did this week was I contacted all the leads for the vaccination centres, and I said to them, I'm going on an IIOP webinar this evening, Wednesday evening. If you would like me to put up a slide that has contact details for the HR person who's recruiting the pharmacists in the medicines management roles, then let me know and I'll happily share those details. So as of 5 o'clock this evening, I got the last, so all 38 COVID centralized vaccination clinic contact points, if you would like, or your colleagues would like, or any, it's a medicines management team, it's pharmacists, it's technicians, it's people who have experience of working in pharmacy shops. I would encourage pharmacy students, put your name in the hat if you're thinking that you would like to do some work in these clinics. Maybe they're fully staffed, maybe they're not fully staffed. I actually don't know the staffing status of all of them, In fact, I have no insight really, but those are the details of how to contact these people, because while National HR is taking on the role of recruiting the vaccinators, all other roles are being recruited locally, because of course National HR would be swamped if they took on that. So all the other roles, and that includes this Marsden's management role for the pharmacists, is being managed by the, and these are the pharmacy contacts. And Joan has incredibly generously put up her own name for the Dublin Midlands. Anne Hartnett, who's the chief pharmacist, I have no idea how the woman has enough time. In Limerick is taking caught that ball for Limerick. Donald Carroll is doing it down there, Kilkenny, Carlow, that end of the world. So sometimes they are pharmacy colleagues, sometimes they're HR contacts. And these are the contacts. So IIP have said take a screenshot, or they're also going to email them out. And I'd really encourage you to share them. One of the questions that came up, are you expecting recruitment issues? Of course we are. Pharmacists, we're really scarce. There isn't an awful lot of us. So I think that it will be, and to me, this is very, you know, one of our things is we monitor the ICU drugs. For the country, we keep an eye on the supply chain, and you know we're assuming that wave 4 will come, and we're hoping wave 4 will look like wave 2 and not like wave 3. But vaccination is part of this. So Brian Cleary alludes to it as a war effort. He says, you know, Fionnuala, this is the emergency of our generation, and we need to just get on it. And I think he's telling me I have to work harder. But anyway, we'll move on from that. So I'll stop talking. And is there any? So all the contacts are up on that screen. So I just go for it. If I can take questions, Catherine, that's the end of my...
Yeah, thank you. That's brilliant. Thank you so much, Fionnuala. And I know, Fionnuala, you've been looking at the questions box. It's been super, super busy. I'm hoping that actually you've covered some of the questions that were asked earlier on in the chat box. One theme that cropped up, which I'll just pull out just to clarify, is that quite a few people are talking about, you know, I suppose being impressed by the City West experience and talking about how can they feed forward? Is there a way that we can streamline best practice between different centres? Is there a way of, you know, of like feeding forward in that regard?
You know, we did when the hospitals were vaccinating, we had weekly chats with the hospitals, and the privates, the publics, the CHOs, the acutes. I think it's a really good idea, and I think that it could be as simple as there's a somebody, you know, all we did was we put up a Teams call and then invited people to the Teams call. So it would just be a question of getting the contact details and then scheduling a Teams call and somebody facilitating that Teams call. So that's a really good idea. And to be honest, isn't it shocking that hadn't occurred? I don't know where that would live. You know, we're meant to be the design team and not the operations team, you know, the usual rubbish. But we'll figure that out, Catherine. I mean,
yeah, and I think one thing which is always really fantastic about these I suppose this forum, when we have everybody sharing practice and sharing insights, is that we can really take them away, because as we've just, Fionnuala, you said, you know, you're so in the detail that sometimes it's really good to get people working from different perspectives to be able to feed that back. So we'll make sure that we capture all of this feedback in the chat box and we make it available. Now, either Fionnuala, I can pick out some questions. I don't know if perhaps Muriel or Joan as well might have seen some questions they'd like to answer, but there are a couple that I think I can probably pick out. There's one question saying, is it going to be mandatory for all vaccination centres to employ the ratio of pharmacists in relation to the vaccination booths? I guess the question being, if not enough pharmacists are recruited, what's that going to look like?
That's a really good question. And we've put in that we can have ancillary staff. So, you know, traditionally in hospital, we would be in the pharmacy tech mode. And we had to say, well, look, the HSE has lots of grades codes, lots of staffing codes, and pharmacy students, technician students, people who, and one of the things we've said is, you know, if somebody applies, go talk to the lead pharmacist, because we have colleagues who have great community experience but mightn't have gone through formal training, and they are still very competent and very able colleagues who would play a blinder. And I would encourage anybody to apply. And the hope is that we have enough cross-trained people in our community. And also, I mean, I'm encouraging my team, you know, if you're a HSE pharmacist, there's already an arrangement that we can work in these clinics and extend our hours. So I'm encouraging my team, and I when it gets busy, I know I will go down to City West and I will do as many shifts as I can accommodate. again, it's that piece where I just know that if we don't make sure that we get to use all the vaccine that fast enough, we'll just have a harder time coming. But I don't even want to think about it. And my hospital colleagues definitely don't want to think about it.
Absolutely. One question that certainly we've been hearing a lot this evening and has come up certainly in terms of the IOP help desk is around pharmacists that are wondering whether they can be helpful if they're working full time but would have time at the weekend or evenings. Is that something that can be accommodated?
Absolutely. I mean, these clinics are open. One of the models I did the ratios for was 98 hours in a week. Now that's basically almost 3 working weeks. So, and as Joan said, pharmacy are going in first. They're getting everything ready. So when vaccinators arrive, they're ready to go. And pharmacy is staying last in the evening to make sure all those files are back in, the reconciliation against the operations list. And actually, like Joan found a problem with the IT system because she came out and said, you know, we have 1,000 vaccinated today and operations went 960. And Joan found the problem because she was able to tell them from pharmacy's point of view how many doses went out. And so, sorry. So yes, in answer to your question, stop going down tangents. You're quite right. Come back, Catherine. So yes, absolutely. Because I mean, I'm working full time and so I won't be able to be out there for 37.5, but it'll be a nice place to be there a couple of evenings a week, I reckon.
Absolutely. It's hard to pick questions. I'm going to. There's one question that I've heard a few people asking. So in terms of the question is the separation of the dilution of the Pfizer vial from administration happening at all centres? Is that the official guidance? So the separation of the dilution from the
central vaccination clinics are working off AstraZeneca, so it is not something we've had to face. What we know is that some of the GP-led are automatically doing it themselves. The hospitals were doing it. You know, I went to 5 hospital clinics and all of them were separating that step. And then we know that some of the GP practices are doing it and some of the big GP clinics aren't. But as they talk about it among themselves, they're moving over to that model.
I am. Oh, it's actually, do you know, this is brilliant. Lots of people are actually answering each other's questions, which is fantastic. Some people are recommending clinical documents and other people are feeding into that. So that's great. Is there, if anybody feels there's a burning question that I'm missing, would you either put it into the chat box? Because I feel like a lot of the questions that have been asked have been addressed by the panel and we are gone past 9 o'clock. So is there a burning question that we really want to close off before we close this webinar this evening?
Some of these are very, very, very hard clinical questions. I wouldn't know the answer. No, the responsible person can't work 98 hours a week. Good God. Good God, the working time directive should be. What they do is, you know, and that's why we have SOPs, and that's why we just want to kind of set it up that everybody knows what they're doing, they get on with it. In each clinic, like on each day, there should be somebody who's nominated to be the boss person. I mean, we all need that. We all need to know that when things get complicated, who makes the decisions, and that person. So responsible person won't be the same person all the time, but you know, there needs to be somebody whose job it is to say yes or no, or to work with the operations lead.
Yeah, perfect. There's a couple of questions that I don't know whether you can answer or not, and that is where to get dead weight syringes in community pharmacy. It might not be a question you can answer, Fionnuala.
The wonderful, amazing, phenomenal thing is that when my community colleagues are vaccinating, the consumables will come out from the HSC, and all the consumables that the HSC have are low dead space syringes. So you don't need to do the work. They've done the work for us. They're incredible. They're very undersung. From PPE to these, they're undersung heroes of our health system, to be honest.
Now then, there was a question that I saw saying, what does DML stand for? What does DML mean?
Dublin Midland.
Dublin Midland.
Oh, Dublin Midland. Okay. Sorry. That was an easy one. Okay.
I apologise for using abbreviations.
Yeah, TLAs. And Joan, it's not even DML anymore, it's DMHG.
Yeah, I know. Sorry, that's a real old one. Apologies. Old dogs, new tricks.
The question is when does the recruitment drive start? And I think that's a question that a lot of people are asking. And I guess it's happening.
Oh, get in touch.
Get in touch, yeah.
Like there's a name for every single, your local one. And I was thinking, if I was a pharmacy student and I was heading back home to Tralee for the summer, nice one, there's a vaccination centre in my town. I could line up and get my summer job there. Do you know, I was thinking the great thing is that because they're all over the country, there is actually going to be places for every one of us who want to work in this to do it. You know, it isn't that we have to go to one of the big urban centres or Cork, for example. Couldn't possibly do that. I'm sorry, pharmacist, whatever. There's 2 different application processes. If you choose to apply down 2 different streams, absolutely. Whatever you want to do, you know, at a certain point, I suppose they'll ask you when you want to work, and then there we go. Yeah. Volunteering rather than paid role.
Yeah.
I did get asked about a question about this in the West of Ireland, and I answered it. I would say if you're in the West and you're interested in getting involved, why don't you contact, because I did answer this question centrally, but I don't know if the answer got out to the people asking the questions, and I suspect not from the comment. Go and contact that person and say you want to volunteer. Just, you know, get in touch and say, I've talked to National, you know, I didn't get the answer out of National, but I'm still here and I'm still willing and able.
Fionnuala, it's Jeanne from the Ioneer, but I'm also the pharmacy lead for Aviva. Sorry, I didn't get to talk to you earlier on today, but if anybody wants to contact me in the Aviva, I'm happy to take questions, put my mobile number out there. It's been a very positive experience overall in the Aviva. I've been there since it opened, and we're vaccinating disability and mental health services now for the last few days. And we've had to take it slower because you're dealing with like people that are light sensitive, sound sensitive, severely autistic and stuff like that. So you can't have a mad stampede of patients going through it. Yeah. And this has been the case the last few days, and even some of the days last week. But in other cases, there's been queues of over 150 people waiting. So for instance, on Sunday. So yeah, but if anybody wants to contact me in the Aviva, I'll put my mobile number out there.
If you just provide it to Audrey or your email to Audrey, I'd say, Jane Ann.
Yeah. Fine, perfect.
Yeah. And I'm sorry I didn't get to chat to her earlier. We missed each other multiple times. And Deirdre Lynch, what are you saying about Cork versus Kerry?
Oh, is that what that was? There's a question, somebody, I'm not sure if this has been answered, but what's the likelihood of pressure coming on site to employ pharmacists? I think you might have answered that one, Fionnuala. Is that around the mandatory rate, the ratio of pharmacists?
But like I said, to be fair to the sites, they really have struggled to know it. And I would say, to me, it's like, the pharmacists are pharmacists, we do what we do, but it's not, that doesn't make sense to everybody. So the model will go out, the model like it is a document that was approved today, and that's going out, and National HR, there is a standard operating model, and increasingly sites are being communicated with that they need to stay with the national models to standardize the experience. Otherwise, you know, you start getting weirdness around people saying it's different here and it's different there. And you can just imagine the media pressure if that starts evolving.
Yeah.
But at the same time, you know, people are really keen locally and they want to run and do their thing. So there's a huge balancing act happening at the moment.
Absolutely. One thing that I think will be very, very welcome is that all the questions that people have had, now that there is, you've published a table which gives names of people to contact. So my understanding is that the questions that people have can now be posed to these people in their regions, which I think is something that was really, really, people were looking for that. So it's great to be able to share that now.
And the speed at which these names came back to me tells me that they're only delighted to hear, because they just have figured out how to do this.
Yeah. Absolutely, and we'll make sure that we make that very accessible to people tomorrow.
I didn't put any typos in it.
Look, I suspect we could keep going all evening. I hope everybody has gotten what they wanted to get from the webinar. Certainly lots of nice comments saying thank you very much, and very much commending the panel on all the hard work they've done. Oh, you've really made a mistake slurring Cork there, Fionnuala. You can get away with that one.
Just saying, your local GP, the procurement have the syringes, so they need to go back to, and I understood that GPs have my sister's GP, the relationship manager piece. There are the syringes out there. You won't be able to buy them. Japan can't buy them, so you won't be able to buy them. And if you use a regular syringe, you definitely get less doses out. You physically can't get the full whack out. So encourage them to go back into HSE procurement.
Okay.
It's really important.
Brilliant, that's perfect. Audrey has just posted the survey into the chat box. It is actually, we really do look at the survey. We use it to feed forward in terms of into how we deliver the webinars in the future. So please, if you could take a second to do that, that would be fantastic. So it's 9:10. So look, we're all, everyone's working super hard. I'm not going to keep you on the line. We'll make sure that all this information is collated and that it's shared, so that we really make the most of all this best practice that's been shared. So all I can do really is thank my panel most sincerely, so Fionnuala, Muriel and Joan, for a super session, and for everybody else, they've worked so hard to pull this information together in this very real-time way, so thank you so much. And yeah, looking forward to getting cracking, getting stuck in. So
Have fun.
I'm going to say good night and thank you, everybody.
Thank you all.
Thank you. Good night.
Good night.